Good evening and welcome to tonight's Men's Health webinar with Dr. Abram McBride. Tonight, we will discuss the signs, symptoms, and treatment options for erectile dysfunction and stress urinary incontinence. You are encouraged to ask questions anytime during the presentation. To do so, simply navigate to the chat function on the toolbar of your screen, whether that's a laptop, a tablet, or your cell phone. Type in your question and hit submit, and Dr. McBride will answer those questions at the conclusion of the webinar. So without further delay, I'd like to introduce Dr. Abram McBride.
Hello, good evening, everybody. Thank you for attending. So tonight we're going to talk about men's health in general. It is the beginning of June, which is Men's Health Awareness Month. So we thought this would be a fitting time to talk about a few important topics: erectile dysfunction and stress urinary incontinence. So first we'll talk about erectile dysfunction, but before we move on, just a little bit of an introduction about myself. I am a urologist. I am a physician. I did not stay at a Holiday Inn Express last night. So I basically see guys with guy problems. I am a urologist. I did a fellowship in men's health, medical treatments and conditions and things like that. And so obviously that's pretty much all my practice is. So let's go ahead and get started. So erectile dysfunction. And what is ED? What is erectile dysfunction? I think that's the first question we have to answer. And basically, ED, or erectile dysfunction, is the inability to achieve or maintain an erection firm enough for sexual intercourse. Some of you may already know this, but some of you may not. It's actually quite common. Much more common than most people realize. About 1 in 5 American men will have ED at some point in their lifetime, which is about half of men over age 40, or roughly about 39 to 40 million men in America. So that's a lot of guys that have ED. So to understand what ED is, we have to know a little bit about how a normal erection takes place. And so on your screen here, we have two pictures, one on the left that says flaccid, the other one on the right that says erect. So basically, inside the penis, and I don't know if you can see my pointing here, but there's two large spaces inside the penis called the corpora cavernosa. And essentially, when you're sexually aroused, you're with your partner, blood flow goes into those hollow natural spaces, the corpora cavernosa. And as blood fills those spaces, the penis grows and stretches until you have an erection. And you can see on the right side here, those corpora cavernosal spaces are completely filled with blood, and the patient has an erection. So the first part that's necessary is blood flow has to come in to achieve the erection, but also there's a very delicate network of cellular architecture in those spaces that traps that blood flow so that the erection can last long enough to finish sexual activity. So any problem with that process, whether it's blood flow coming in or blood flow not being trapped to maintain the erection, any issue can lead to erectile dysfunction. And as you can see here in this graph, there are many different issues, illnesses, medical problems, et cetera, that can contribute to ED. And by far the most common are vascular disease or diabetes, but it could be a side effect of a medication or a result of pelvic surgery, perhaps for prostate cancer treatment or other types of cancers that originate in the pelvis. And so we'll talk about these more in detail as we move along. But the other important point I really want to make here, and if there's anything you take away from this talk, is that erectile dysfunction can have a very significantly negative impact on a patient's quality of life. And what I mean by that is having ED can, for some men, make them very depressed and feel isolated and have self-esteem issues. And so it can affect a lot of other aspects of your overall quality of life besides just being able to perform sexually. So we'll talk about a few of these common causes of erectile dysfunction. And first we have diabetes. And we know that diabetes, unfortunately, this data is a little bit old at this point, but a lot of men are affected by diabetes, about 15 million or so. And unfortunately, I think that number's only risen since 2015. But for those men who do have diabetes and erectile dysfunction, their symptoms of ED tend to be less responsive to our standard treatments, meaning that the symptoms of ED are more severe or significant in these men who have diabetes. But taken from a different perspective, and this is I've had this experience in my practice with a few patients is sometimes guys will come in who have issues with erections or ED, and we evaluate them and we discover diabetes. And so I have diagnosed some patients, even as a urologist, I've diagnosed some men with diabetes because I'm evaluating them for their erectile dysfunction, and we do some blood work and find that for them and get them treatment. But how does diabetes affect the penis and blood flow and things like that? Well, remember, a lot of our relationship, our stimulation, our emotional connection with our partner is at the brain level, but obviously physical stimulation occurs at the level of the penis, and there has to be a connection between the brain and the body, if you will. And diabetes, unfortunately, is a disease that can damage the nerve system, and the nerves that communicate the message from the body to the brain or vice versa can disrupt those signals. But also diabetes can damage the small blood vessels in the body. And we know that the blood vessels that bring blood flow into the penis are indeed small blood vessels. And so those can be damaged as well. Switching gears a little bit, erectile dysfunction and heart disease or vascular disease, another very important relationship that a lot of men with ED will have concurrent heart disease or vascular disease. And I think the most important part of this topic is the fact that symptoms of erectile dysfunction may develop a few years before symptoms of heart disease. Meaning, again, I may see a patient in the office to evaluate erectile dysfunction. 2, 3, 5 years later, they may then have a heart attack or a stroke or chest pain or something like that. And so it's always a bit of a public service announcement on my behalf to make sure these patients are aware of this relationship. But the reason there's a connection there is basically because of the size of the blood vessels. And so in this graph here, you see on the far left, the penile artery is approximately 1 to about 1.5 millimeters in diameter, which is quite small, compared to the main artery here, more in the middle, that would supply blood flow to the heart, called the coronary artery, is usually about 3 to 4 millimeters. And then we have the carotid artery that goes up into the brain, is about 5 to 6 millimeters, and then on from there. And anytime about 50% of one of these vessels is occluded, then blood flow downstream is significantly affected. So in the case of the penis, the artery is only about a millimeter and a half. It doesn't take a lot of plaque and buildup to cause a blockage, which would otherwise take a lot longer amount of time to block one of the arteries that goes to the heart or the brain. And so that's why symptoms of ED may occur before symptoms of heart disease or vascular disease. So what can patients do to improve their lifestyle and perhaps improve their symptoms of erectile dysfunction, but also lower their risk for diabetes and heart disease? And I'm sure a lot of us have heard these things before, things that I still need to follow and work on myself. I'll tell you that much. But, eating a healthy diet, having an active lifestyle, physical lifestyle, exercise, losing weight, maintaining a healthy body weight, staying away from smoking, and reducing stress, or at least managing stress in a healthier way. So those are things that patients can do, that you can do to reduce your risk for ED and heart disease. So we talked about the two most common causes of erectile dysfunction. Let's talk a little bit now about, excuse me, what can we do to treat erectile dysfunction? So you have symptoms. What are the treatment options that are available? And really, in 2022, where we sit today, these are the mainstream gold standard options that we have available. You have pills, injections of medication into the penis, vacuum erection devices, medication suppositories that can go into the urethra, and penile implants. And so we'll briefly speak about each of these and give a little bit of detail. Now, I'm sure everyone on this meeting here this evening has heard about the pills, Viagra or Cialis. They've been around for over 20 years. And contrary to popular belief, these treatments will not just give you a spontaneous erection out of the blue. You take the medication, you then have to engage in sexual activity with your partner, who hopefully you're attracted to and aroused by, and then those medications basically just increase the amount of blood flow into the penis to make the erection fuller and last longer. They're quite effective. I would say about 75–80% of patients will get some positive response from those medications. but they do have quite a long list of side effects, and many of you may have already tried these and know that you could get a headache or facial flushing, blurry vision, heartburn, backache, so forth and so on. And really, I think that leads to a lot of men discontinuing the use of those medications. But we also know that about half of men who use these medications for a period of time, eventually they just lose their effectiveness and they move on to something else. The only real precaution to know about with these, they're actually very safe for men from a heart perspective. You just have to be careful that you do not take these along with medications called nitrates, which the combination can severely lower your blood pressure. Other than that, they're actually very safe from a heart health perspective. Now, another very commonly used mainstay treatment in treating erectile dysfunction, if you live in Colorado Springs area, you hear this advertised on the radio all the time, and that's penile injection therapy or intracavernous injection therapy. And essentially, this is where the patient, as you see in the picture there on the right side of the screen, the patient draws up medication into a syringe and then injects that directly into the body of the penis. And those medications are very potent vasodilators, which means they open up the arteries to allow blood flow into those natural cavernous spaces that we mentioned earlier that are supposed to fill with blood flow. And this type of medication will definitely give a patient an erection, whether they're sexually aroused or not. So we actually use this in the office to evaluate patients and their erectile dysfunction or function. And in a patient has fairly good blood flow, they'll get an erection in the office, talking with me and my staff, not aroused, hopefully. And so they're pretty potent in that sense. The problem is the side effects. As you can imagine, the injection itself is a little bit, that's tough for some men to do just psychologically, but also the injection can be painful. But even if the needle itself is not painful, once those medications are active, about a quarter of patients will notice that their penis has an ache, or what I call a migraine, a penis migraine, that can be, uncomfortable. And really the most common reason that men stop using these therapies is related to pain or discomfort from the injection, but also the lack of spontaneity. Remember, you've got that moment with your partner. You got to say, okay, great. This is wonderful. Time out. I'm going to go do this treatment and inject myself and come back. And hopefully your partner is not watching TV or falling asleep or something like that. And so really long-term, about a fifth, about 20%, maybe 25% of patients really use this long-term. Most men will use it for a phase of time and then move on to something else. Now, the next two categories we'll talk about are certainly much less popular than what we've mentioned so far. We have the vacuum erection device. As it sounds, you put your penis into this plastic tube, and it's usually connected to either like a manual pump, like a blood pressure cuff, or a battery operated motor. And essentially that creates a vacuum, which then draws blood flow into the penis to achieve an erection. And for that purpose alone, it's pretty effective. In fact, I have a lot of patients use this for what I call penile exercise after like surgery or things like that. But the issue is really maintaining the erection, and the device does very little to actually help trap the blood flow to maintain the erection, unless you use a very tight constriction band, which can be uncomfortable, cause bruising, swelling, can even cause something called Peyronie's disease. I've seen that happen before. And side effects and lack of spontaneity, of course, I'm sure your partner is excited to see this big device being revealed as a big surprise in the middle of your intimacy. So that's kind of where not a lot of patients use this on a regular basis for sexual activity, but more so for penile rehabilitation. And lastly, medication-wise, we have the urethral suppository. And exactly as it sounds, as you can see in the picture, a medication is inserted into the urethra where you normally pass your urine through. And there's a small applicator that is passed into the urethra where the medication is delivered. And this is actually a medication that's utilized in the injection therapy. It's called alprostadil, but it can absorb through the urethra. And it's about 50-50 in terms of if it's effective or not. The absorption there's a little bit more difficult because it has to go through a lot of tissue to get into the vascular area of the penis. In that that medication itself can be very irritating to the urethra. So pain with urination after using this medication, pain directly in the penis while the medication is absorbing, for a lot of patients can be uncomfortable and lead to their lack of interest in using it as a treatment. Now, I don't want to spend a lot of time here. I'm sure a lot of people have heard about this and will have questions, but there are some investigational alternative treatments that are available. Extracorporeal shockwave therapy or penile shockwave therapy, intracavernous stem cell injection therapy, or platelet-rich plasma or PRP therapy. And the first one, the shockwave therapy, actually, while as of today it's not FDA approved, it's considered experimental. There actually is a fair amount of clinical trial data, research from Europe. It's been approved for widespread usage in Europe for many years now. And for the right patient, the best patient scenario, this therapy can be effective. And I think that's where there's a disconnect in the United States is a lot of these clinics will advertise it to be a cure-all for anyone who has erectile dysfunction. You've tried everything, nothing's worked, try some shockwave therapy and you'll be cured. I think that's where you got to be very careful. It has to be for the right patient, but we do offer it in our office. And like I said, for the right patient, it can be effective. The other two are extremely experimental. And when I say that, I mean, there's still animal experiments going on. And in even those environments, the results are very mixed. There's very little to no data. In fact, there is no data for usage in men for erectile dysfunction. Now, stem cell therapy, PRP, injections, a lot of data, a lot of benefit in the orthopedic world. Knee arthritis, hip arthritis, things like that can be very effective. But as we have already mentioned, erectile dysfunction is not a inflammatory condition like arthritis. It's a different cause, and so those therapies, even just conceptually, don't really make a lot of sense. So the other option is a penile implant, and some of you may have heard about these, but I've found somewhat surprisingly that a lot of patients have never heard about these, and so it's certainly worth spending a few moments to go over these. But they've actually been around for years, many years, and there's been quite a progression of development. And even today we still have as an option the malleable implant, the 2-piece inflatable, and the 3-piece inflatable implant. But by far and away, the vast majority of implants that are utilized today is the 3-piece inflatable implant. And you can see a picture of it here. And essentially, there is a pump that is discreetly placed into the scrotum. So it's all of it is inside the body. Nothing is seen on the outside or used on the outside. Everything's on the inside. There's a little pump in the scrotum that the patient or the partner can squeeze and release, and that moves fluid into these cylinders, which are inside the penis, into those natural cavernous spaces that are hollow spaces that are already there. And as fluid goes into those cylinders, an erection is achieved, and that erection will last until the patient and their partner are finished or have completed sexual activity, and then it can be deflated. So it gives the patient really complete control, 100% control over when the erection happens, how long the erection lasts for, and in some cases you can even control, if you want to, how firm and rigid the erection is. And so for some patients and couples, I've heard that the partner likes to have that degree of control, maybe doesn't want a fully rigid penis. So anyways, a lot of control for the patient in that sense. And really, when you look at the research where patients are surveyed about if they have an implant, what they think about it, patients are very, very satisfied. Over 98% of patients and their partners are satisfied with the result. But it is a procedure, and we'll talk about that more here in a second. Procedure to have it put in. But before we do that, I want to show this video, and I think this is important to kind of help conceptualize. So some of these things I'm describing are a little bit abstract and hard to see. So in this computer-generated animation, on the outside, there's no parts or pieces that are visible to anyone else, okay? But when you feel around in the scrotum, you can see, I'm just going to pause it here, there is the pump that the patient is squeezing, and that is inside the scrotum in front of the testicles. And as you're squeezing and releasing that, fluid moves from this little reservoir that is up underneath the pubic bone and then moves into the cylinders. And as that continues, an erection is achieved. And the erection, once it is achieved, will not deflate or go away until you push the deflation button. And so that's what this person is doing now. They've hit the deflation button. The fluid goes back to the reservoir and the penis goes back to the resting state. Okay. And then, of course, you're in that resting state until the next time you and your partner want to be sexually active. So as I mentioned, it's a procedure. Okay. So you do have to have a little bit of anesthesia to have this put in. But it's a come in, go home, same day procedure. So it takes about 45 minutes of actual, 45 minutes to an hour of actual time in the operating room. But usually about a half day of time in total, but by the time you get there and go home afterwards, usually within a few days, 5 days, 7 days for sure, patients are back to their routine daily activities. I always tell my patients 2 weeks, don't mountain bike or climb Pikes Peak or something like that for 2 weeks, but get in the car, going to a doctor's appointment, running some errands, 5-7 days is pretty typical. And then you'll see me or one of my PAs in the office, and we'll teach you how to use the device around 3 weeks. Okay, so 3 weeks you start using the device. In 4 weeks, most patients are independent and they're sexually active and they're being intimate with their partner. So we've talked about a lot of these benefits already. I'm not going to read all of these, but high satisfaction rate puts the patient and their partner in complete control, allows you to be spontaneous. Okay, you want to take a trip to Europe, take a trip to Antarctica. Everything you need is already with you. Okay, you don't have to take an extra supply of medication or things like that. It's a very durable result. So I haven't talked about this, but typically these devices will mechanically, I tell my patients, expect it to be mechanically good for 10 to 15 years before it could wear out. So a lot of great benefits. And a question that always comes up, and I'll go ahead and address it now. That may be one of the questions in the chat box, actually. The implant does not have any impact on the nerves or the sensation to the tip of the penis or the outside of the penis. So sexual activity will feel the same. You'll still be able to orgasm. You'll still be able to reach climax. Your partner it'll feel the same to your partner. All the implant does is allow the penis to be rigid and erect so that you can participate in sexual activity. Okay. So downsides, it's a procedure, right? We mentioned that. There's always some risk involved. Anything there's a risk of bleeding or infection. Specific to infection though, any implant that goes into the human body, breast implants, knee replacement implants, hip implants, pacemakers, all of them have a risk of infection. And typically that's around 1% to 2%. And the same is true for a penile implant. That risk is about 1% to 1.5%. Now, if the patient has diabetes, it's just a slightly higher risk, about 1.5% to 2%, as long as they maintain their diabetes under good control. The other thing is mechanically, these devices wear out. So I tell people 10 to 15 years, but sometimes patients find themselves needing an implant earlier in life. And so it would have to be another procedure to have the device removed and replaced if there's any type of mechanical issue down the road. So in summary, ED is extremely common. You probably know many men, neighbors, church, social circles that have ED. There's a lot of treatment options available. Penile implants, of all the treatment options that we discussed, provides the most durable, long-lasting result and restores spontaneity. Okay, so we're going to switch gears a little bit here and spend the rest of our time talking about male stress urinary incontinence. That's a mouthful. So what does that mean? Stress urinary incontinence. So basically that means that someone is leaking urine uncontrollably, and it's called stress incontinence when you're leaking urine with coughing or sneezing or laughing, or like I'm sitting in a chair and I stand up and all of a sudden I get a gush of urine because I can't control or hold that urine flow back. A lot of men, 500,000 men approximately worldwide suffer from stress urinary incontinence. 500,000 men is a big number, but certainly a much, much smaller number of men than what we talked about with erectile dysfunction. So these men are out there, but typically it's a result of something specific, and we'll talk about that here in a moment. But to understand urine leakage, we have to first understand, how do we normally urinate? And so in this picture, I don't know if you can see my pointer here, but you have your bladder, and your bladder is a storage sac that contains or holds the urine until it gets full and you feel like you need to urinate. And when you get that sensation, mentally you say, okay, I'm going to go to the bathroom, and you relax. And on either side of the prostate here, particularly below the prostate, is the external urinary sphincter. And once that relaxes and opens, urine flows and the bladder is empty. When you're done urinating, though, this muscular sphincter is supposed to clamp back down and block the flow of urine, so that way urine is stored in the bladder until the next time you're ready to go to the bathroom. So understanding that makes it a little more easier to understand how someone can get urine leakage. Is if that system doesn't work properly, then obviously urine goes in the bladder, but it doesn't store it because it all just leaks out through the urethra. So by far and away, the most common cause of urine leakage or stress incontinence in men is prostate cancer treatments. In particular, prostate cancer surgery. You're removing the entirety of the prostate for prostate cancer reasons. And we know that about nearly 100% of men will experience urinary leakage right after their surgery. But even at a year, anywhere from 5 to 10% may still experience ongoing leakage and seek treatment. But urine leakage can also be the result of other forms of pelvic surgery for, say, rectal cancer or colon cancer, prostate radiation, trauma, a bad car accident, a fall from a ladder or off a rooftop. I've definitely seen that before. So there's a lot of things that could happen there. But as you can imagine, urine leakage or urine incontinence can be extremely distressing to patients, and it makes you isolate yourself. You're embarrassed, or it's hard to wear clothes because you're wearing bulky pads, or you're getting wet spots, which leads to isolation, depression, and it's really pretty terrible what a lot of these men have to go through until they get treatment. So real quick, before we move on to the different treatment options, I want to drill down a little bit more on this connection with prostate cancer and prostate removal. And so in the picture here on the left, you can see you have the bladder, the prostate in the middle, and the urethra. And right here between the prostate and urethra is the external sphincter that normally clamps down and holds the urine flow back until you're ready to go to the bathroom. So when your prostate is removed surgically for prostate cancer, obviously the prostate is gone, and that's what we have here on the right side. So we have our bladder and our urethra and the urinary sphincter, but there's no prostate there. And so the surgeon has to reconnect those two back together. And in doing so, the muscular sphincter that normally would contract and hold that urine flow back takes some time to recover. So if you find yourself in a situation, what can you do? And what do I hear patients tell me that they do? And really, there's sort of short-term, or what I call a Band-Aid fix. And one Band-Aid is stop drinking fluids. Okay, so fluids are coming out. You got to have fluids going in for them to come out. So patients will just intentionally dehydrate themselves. And so obviously that's not good for your overall health, kidney function and things like that. But that's what some people do to adapt. You can wear pads, you can wear clamps, condom, catheters, things like that to try and absorb the urine once it's already leaked out of the patient. Or you can try and strengthen the urinary sphincter, the muscular sphincter. And so patients will go to physical therapy and do pelvic floor exercises, Kegel exercises to try and strengthen that muscle to help better control the flow of urine. But for patients in whom they no longer wish to do those Band-Aid options, or if going to physical therapy just is not effective and the muscle, the sphincter muscle is just not responding, we have some long-term options, and really there's two. The first is the male sling system. And you may have heard of slings being used in women for urinary leakage. The same is true in men. And essentially the sling just functions as a hammock to provide support underneath the urethra, which increases the resistance in the urethra and slows down the flow of urine. Advantages of the sling are it's not detectable to others, right? So this is completely put inside the patient. In the appropriately selected patient, which is really the patient who has very, very limited or mild urinary leakage, it can be very successful. The patient doesn't really have to do anything. So once you have your sling placed, you just go to the bathroom the way you've always done your whole life. And the sling is just kind of there all the time in the background helping you out. And a large number of patients are satisfied. About 92% would suggest that they would repeat the procedure if necessary because it worked pretty well for them. Now, in contrast to the sling is the artificial urinary sphincter system. Now, this is what we would consider to be the gold standard treatment because it can work for pretty much any degree of urine leakage, whether it's a few pads a day, 5 pads a day, you're soaking 10 pads a day, okay? Anywhere on that spectrum, the urinary sphincter can be very effective at controlling the flow of urine. It's also private and discreet, so people aren't gonna sit next to you and know that you have a sphincter device. Even if you're at the YMCA or the gym taking a shower, no one's gonna know that you have this. And it functions very similar, almost exactly to the way our natural muscular sphincter works. And so basically the patient has control over this device. And really this device, as you can see in the picture here, it's kind of similar in concept to the penile implant, but essentially you have a cuff which is constantly squeezing around the urethra. So instead of urethra being open, it's compressing and squeezing the urethra closed 24/7 until you feel like you need to go to the bathroom. And when you get that sensation or that urge to urinate, you then squeeze the control pump, which is also in the scrotum, under the surface of the skin, easy to find. You squeeze the control pump and you have about 90 seconds or so for urine to flow and the bladder to empty. And then after 90 seconds, that cuff will squeeze again and you're back to having control over the flow of urine. And so similar to the penile implant, I want to show this video just to help drill home the concept of how this all works. And so another computer animation here, and you can see the different parts and pieces. And that's the control pump there inside the scrotum that the patient's about to squeeze. And once you squeeze that control pump, the cuff opens around the urethra and urine can flow. And once the bladder is empty, which happens pretty quickly, the system will automatically reset itself and that cuff will start squeezing the urethra and compressing the urethra again. So again, this is a procedure to have put in, the urinary sphincter device, but it's a come in, go home same day, much like the penile implant. 2 small incisions are necessary, but again, 5 to 7 days, you're pretty much back to most of your normal routine daily activities. Now, we do need to wait a little longer for the urinary sphincter device, typically 4 to 6 weeks before we teach patients how to use the control pump and have them start using it at home. That's just to make sure that the urethra has had sufficient time to heal. But similar to the penile implant, patients are very happy with the sphincter device. About 94-95% of patients are satisfied, and anywhere between 90 and 94% of patients would recommend it to a friend or have the surgery repeated if necessary. And I don't think we cover the downsides, but obviously, with sphincter device, much like the penile implant, potential downsides are infection. So the device is implanted into the human body. Just like we talked about earlier, there's always a small risk of infection with any implanted device. Mechanical dysfunction. Typically, these sphincter devices mechanically are durable about 8 to 12 years. But they could erode through the urethra, or there could be atrophy of the urethra that would require some type of revision procedure at some point. And so again, just like with the penile implant, the urinary sphincter device, anything that needs to be fixed or corrected would require a second procedure to do that. So what are the benefits of treatment for urinary incontinence, stress urinary incontinence? It allows the patient to have control. And I think that's the biggest thing, right? These patients really are distressed. If you're listening to this today, you may be experiencing this, and it's tough to deal with. But it gives you control over that bodily function. All the parts and components are inside the body. It's concealed to other people, and there's associated with a high satisfaction rate. So we talked about some of the downsides of the procedure. And so at this point, I think really just want to drive home the point that in summary, we have options. If you're leaking urine uncontrollably, you're wearing pads, things like that, there is another option out there. There is something that can help give you control of your urination once again. And so I think for a lot of men, they don't know that, and they just suffer on in silence. And so we have options available. There are options that can be very effective. And so I think a great website, if you want to learn more information about options to control urinary leakage, great website is fixincontinence.com. Okay. And in general, I just want to thank everyone for your time and attention this evening. We're going to take questions here in a moment, but that's my contact information for my office. But also I have a website that's worth checking out, has a lot of information that we've shared this evening that you can reference, and that's themensmd.com.
This time I'd like to introduce Cliff Pollock, who will take us through his journey with erectile dysfunction and how he treated that.
Well, good evening, everyone. What you're going to hear basically is the trip, the journey I took from the time I did have erectile dysfunction through actually conquering erectile dysfunction. And when I was 50 years old, I was diagnosed, 58 years old, I was diagnosed with prostate cancer and decided to have my prostate removed, and found out after having my prostate removed that I ended up with ED. So they decided to put me on Viagra. And unfortunately, I was one of the patients that had terrible, terrible headaches from the Viagra and all the other pills, to the point where when I would take the pills, I would get such bad headaches, I just had to lay down and I just could not pick my head up off the pillow. It was just really bad. Went back to the doc, and they told me to use the external vacuum device. And the external vacuum device does work, as Dr. McBride said. Unfortunately, it truly is not very spontaneous. The other thing is your penis turns a little blue, it turns cold, it does not look normal. And that really kind of turns off your partner a lot of times. So after about 3 months of playing around with that, I didn't know what else to do. And I just went into a major, major depression. And for the rest of about 2 years, I just felt like I was the only person in the world that had this problem. Guys don't speak a lot to other guys about this. Luckily, I got an invite to a seminar like this, and found out about the other treatment options. I wasn't too interested in the little pellets, and truthfully, I'm not a person who likes injections. So my wife and I talked about it, and we decided that the best option for us was the artificial, inflatable penile prosthesis. So the day after my 60th birthday, I had the surgery done. And I will tell you, that is the second best thing I ever did in my life. What it did is it brought me back to reality, and it brought me back to a lifestyle that I had lost, and an intimacy that my wife and I had lost for over 2 years. When I got the device, they sent me home with medication. I have a very high tolerance for pain. There was not a lot of pain. I was able to go just with Advils. And after about a week, I went back to work. And after 3 weeks, I did go back to the doctor's office, and they did show me how to use it. And I did pump it up a few times a day and release it just to get used to it. And about the end of the 4th week, beginning of the 5th week, my wife and I started to have relations again. It's really great going from being the only person in the world that has this to being 18 years old again. It really works great. I've had mine for 14 years before I had to have it replaced. So when I was 74, I had it replaced. I am now 76. I've got a new one for the last 2 years. I will say and let you know, it is just as good, if not better, than the old one. It has never, ever failed to give me a rigid, solid erection, good for any type of intercourse you would like to have. Another thing that's nice about it is if you have a partner that has not seen you before the surgery, they really can't tell you have something inside you that's not natural, because the erection is totally natural. And your feeling of orgasm, like the doctor said, is totally natural. So there's nothing that you lose by having this implanted. The things you do gain are the fact that with pills, with injections, you know, you can get a priapism. You can have an erection that lasts more than 4 hours and you're at the hospital. I tell you the truth, you can leave this up for 4 hours or 40 days. You become the Energizer Bunny. You leave it up as long as you want, which really helps out. People ask me, the two major questions I get asked is, what happens when you go through the airport and you go through the metal detector? And the answer is absolutely nothing. It does not ring any bells or anything. And if you're like me, I have artificial knees, so the bells do go off and they take you to the side and they want you. I don't know if you've ever been wanded before, but they take this wand and run it up and down your body and on the inside of your thighs and around your crotch. Nothing goes off and they send you on your way. The other thing is, people have asked, does it interfere with anything that I have to do with my urination or bladder issues? And the answer is no. You can still have, if you need to have a cystoscopy, it's not an issue. It's not a problem. The only information I would give you that might be a little different is, I believe that ED is not just a male issue. I think it's a partner's issue. And I say that is, I speak to a lot of men who tell me my wife or my partner is very upset with me. They think I'm having an affair with somebody and I don't love him anymore and I can't get an erection because they don't arouse me anymore. And as you know, that's the farthest from the truth. So my suggestion is, when you go to see the doc, if you can, take your partner with you and let them share what the issue is, because it will make a major difference. And all I can say to you is, it is the best thing I've ever did. I've been married 54 years. I've only had this for 16 years now. I'm 76. I hope it'll last another 12 years and I'll do it again. So at this point, I'll turn it back to the doc. If you have any questions, I'll be more than happy to ask.